Welcome everyone. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, Strategies to Prevent the Spread of MDROs and the Application of Transmission-Based Precautions, featuring A.C. Burke, Vice President of Healthcare Quality at RB Health Partners, Inc. This is the fourth webinar that is part of our webinar series focused on multi-drug resistant organisms, or MDROs. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars and podcasts, sign up for our newsletter, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email us at arcipc@uab.edu. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety, and the Alabama Statewide Area Health Education Centers. You can learn more about their programs and the centers as a whole at the websites listed on this screen. We'd also like to let you know about our next upcoming webinar, Reporting Infectious Diseases and Outbreaks to the Alabama Department of Public Health. This webinar will provide an overview of the reportable diseases and conditions required to be reported to the Infectious Diseases and Outbreaks Division within the Bureau of Communicable Diseases at the Alabama Department of Public Health. During the webinar, participants will have the opportunity to review the Infectious Diseases and Outbreaks Division notifiable disease rules, discuss who should report, how to report, and when to report outbreaks and reportable diseases and conditions, as well as review frequently asked questions from required reporters. This webinar is presented by the Alabama Regional Center for Infection Prevention and Control and is co-sponsored by the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. It will be held May 23rd at 1 p.m. Central Standard Time. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must 1, register for the training, 2, watch the entire program, and 3, complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. For nurses in the state of Alabama watching this program live, CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. For those seeking a certificate of participation, please complete the Alabama Nursing CEU request form, and there will be a place for you to select that you would like to request a certificate of participation. CE units for this program will expire on May 2nd, 2025. If you experience any issues or have questions about the CEUs provided, please email arcipc@uab.edu. We will place this email in the chat box as well. And finally, it's my pleasure to introduce our speaker. A.C. Burke has been working with RB Health Partners, Inc. since 2016 and has over 22 years of experience working in public health and healthcare. A.C. worked for the Florida Department of Health for 15 years. 5 of those years, she served as the Healthcare Associated Infection Prevention Program Manager. She later was the Director of Infection Prevention for Mayo Clinic, Florida. In her current role, she consults with long-term care facilities on infection prevention and control policies, procedures, and practices, and provides training to nursing homes and at conferences, including the 17-hour Nursing Home Infection Prevention Program, Nipping Infections in the Bud. Welcome back, AC. I will now pass things over to you.
Thank you, Mina, and certainly is a pleasure to be back speaking with everyone today, and thank you so much for including me and having me be a part of the MDRO Webinar Series. As Mina said, we're going to talk about strategies for preventing the spread of MDROs and talking a little bit more specifically about the transmission-based precautions. So I am going to talk about some of those general strategies as it relates to prevention, But then I'm going to spend a little bit more time being a little bit more specific about CDC's transmission-based precautions, as well as the enhanced barrier precautions. So CDC technically has not included enhanced barrier precautions under the transmission-based precautions section in their guidelines, and also CMS does not list enhanced barrier precautions when they list the transmission-based precautions. So I am sticking to that technical difference. And enhanced barrier precautions in addition to transmission-based precautions. I suspect that will probably change in the future. And then I'm also going to touch on patient-resident placement as it relates to precautions. All right, so our prevention strategies. So as with many other categories of prevention, we have bundles. We have bundles of prevention strategies. So for cleaning and disinfection, as we've talked about in a previous webinar, so the same for MDROs. So certainly surveillance is important as it relates to helping us with preventing transmission. So we need to know what the history is of MDROs within our organization or within our facility. We certainly want to know if we have any novel or targeted MDROs, and I do have a list of those in a future slide. So surveillance is very important as it relates to MDROs. Having completed a risk assessment. So this can help us identify where we might have potential gaps in our infection control program. It also helps us to identify what the population that may be at risk or at greater risk of acquiring infections due to MDROs. Other things that are taken into consideration when doing a risk assessment would be in terms of our resources or existing resources to help us with prevention. So are we struggling with staffing? How well educated are our staff? In terms of prevention as it relates to MDROs, do we have the resources to support? So do we have the alcohol-based hand rub? Do we have the PPE that we need? So do we have the resources that we need to help us with prevention? And then also, we want to make sure that we are taking action based on the findings from our risk assessment. So we definitely don't want to just be filling out the form, sticking it in the book, checking the box. I've got it ready for surveyors. So we actually want to make sure that we're looking at those results and we're also taking action based on those results. With our surveillance data, it's also important to make sure that we're doing summaries. So summarizing our data over time. And we want to be sharing those summaries and providing that feedback to our providers as well as our staff. So hand hygiene is always important, right? So infection prevention presentation, we always have to talk about hand hygiene. But that being said, a couple weeks ago, I started working on a presentation about Candida auris. And so I was pulling some of the studies, looking at some of the studies that have been done. And one of the studies really caught my attention in terms of looking at the potential for the contamination in the environment, how quickly the environment can become contaminated. And I know we've talked about the importance of the environment and environmental cleaning, but this study also looked at how quickly the environment can become recontaminated, if you will, from persons that are, say, just colonized with Candida auris. And actually, they also looked at MRSA and VRE. And I have to admit, it was kind of astounding to me in terms of some of those time frames, but then it also brought me back to hand hygiene is just so important. We just don't know when we're touching things in the environment, that potential for contamination of our hands, and then healthcare workers being the ones who can transmit those pathogens to others who may be vulnerable for infection. So hand hygiene, very, very important in all aspects of our infection prevention programs. Other components of our prevention bundle, so education. Certainly we need to make sure that we're educating our staff, educating patients and residents, their families, cleaning and disinfection, as we've talked about. We can't forget about standard precautions. I know we get so focused on some of these other things, we still need to make sure that we remember about standard precautions. So when we're doing trach care, we still need to make sure that we are protecting our face, for example, when there's that potential for splash and spray. And then transmission-based precautions and enhanced barrier precautions, which we will be talking about today. And then certainly we don't want to forget about antibiotic stewardship. So antibiotic stewardship is a little bit more of that bigger picture, a little bit more longer term impact in some situations. So we definitely want to make sure that we are trying to be judicious with the use of our antibiotics so that we can help slow the development of multi-drug resistant pathogens. Communication. So we want to make sure that we are not only communicating with our partners. So when we're transferring patients to another facility, so having that external communication, communicating with family members, reporting to public health. But we also want to make sure that we have those internal communication channels in place. So for example, the lab, right? The lab's going to be the first to know. They're the ones doing the cultures, getting those results. And so we certainly want to make sure that our lab knows who they're notifying, how they're notifying, when they're notifying, when they get those results in, as it relates to MDROs and other significant pathogens. And then what are those secondary notifications, if you will, to other providers, other staff? How are we communicating to our staff who has MDROs? So for example, do we have a flag in the medical record or something like that? So just kind of, we also want to make sure that we are thinking about those internal communication strategies as well. All right, so our novel and targeted MDROs. So CDC has given us a list of these. So our pan-resistant pathogens are carbapenemase producing. So many of our carbapenemase producing pathogens, they're in the Enterobacterialis family. So E. coli, Klebsiella, Citrobacter. So very, very common pathogens. They're pathogens that are a part of our normal flora as well. So the carbapenemase producing pathogens that have in the Enterobacterialis family, all the pathogens in that family be included. The carbapenemase producing Pseudomonas, carbapenemase producing Acinetobacter baumannii, also known as CRAB. So another fun little acronym for us in infection prevention. And Candida auris. So we definitely want to make sure that that we're able to identify these pathogens. They are indeed included in our surveillance. And then there may be some additional or supplemental strategies that we implement when we do have these pathogens present within our facility. All right, so identification being very important. So certainly we want to know when people have infections. Ideally, we know who's colonized with the novel and targeted MDROs. Also with the targeted MDROs, there may be additional screening that we want to be doing. So, you know, do we want to be doing any pre-admission or admission screening that's to a targeted population? So seldomly would we ever implement a process where we're screening everybody coming through the door. Typically, it's not realistic. It's not very cost efficient. But based on epidemiological factors, we may have a targeted population based on those factors that would identify who we want to be screening coming into our facility. So for example, hospitals may put screening protocols in place. I can tell you that some of the hospitals, so I'm in Florida and we're doing a fantastic job of transmitting Candida auris. And I can tell you that some of our hospitals, for example, they're screening anyone coming in from a nursing home into their facilities. Some are just screening residents from nursing homes coming into their facilities that have wounds. So the hospitals are kind of looked at some of those targeted screening procedures, but that applies to nursing homes as well. I mean, we can certainly set up targeted procedures. Maybe we're familiar with a hospital that we know has one of those novel and targeted MDROs in some of their patients. And so maybe for the nursing home, we want to set up anyone coming in from a specific hospital based on their history. We may want to screen as well. So that's certainly a two-way street. When we identify novel or targeted MDRO within our facility and it's not, when we didn't know it was there, for example, so then we may look at some various strategies for how we may do screening. So we may want to look more closely within a specific unit or within our facility. Also, if we suspect staff might be transmitting, then we may want to include them in screening. So again, this is really making these decisions is about some of those epidemiological factors to help us guide who we want to include in those screenings. So when we have newly identified cases, again, we're not aware that we've had it, and now all of a sudden we realize that we've had it. Working with your public health staff certainly can be beneficial. So they can help with some of that guidance as it relates to what might that screening approach be. So looking at a risk factor-based approach. What are those epidemiologically linked patients? There may also be broader screening, so it might be unit-based screening, it might be facility-wide screening. So there's a lot of things that would be taken into consideration for making those decisions. So transmission-based precautions. Jump into our main topic here. So in terms of when do we use transmission-based precautions? So per CDC, so we want to use these transmission-based precautions when standard precautions alone does not interrupt transmission. So interrupt transmission of an infectious agent. The language within the CDC isolation guidelines does still state, so implemented when a patient resident is suspected of or known to be colonized or infected with an epidemiologically important organism, novel or targeted MDRO, or highly infectious microorganism. They include airborne, contact, and droplet in their transmission-based precautions. So in terms of defining epidemiologically important pathogens, so some general characteristics that we would be thinking about. So are they easily transmitted? So what is the likelihood of the pathogen being transmitted? How easily transmissible is it? What is the likelihood that it can cause an outbreak? So with that, if it's easier to transmit, is it likely to make people sick? What's the likelihood of causing an outbreak? Also, it can be associated with a severe outcome. So perhaps we might not be looking at a lot of infections, let's say in a large outbreak, but the outcome may be severe. So a high morbidity, mortality associated with it. And then they're difficult to treat. So if we get it, it's very difficult to treat. So those are some of the characteristics of how we identify those epidemiologically important pathogens. In terms of what pathogens would fall under this heading, that can vary by region, based on the prevalence of certain pathogens within your area. So there might be some variation based on geography. So these are some examples of potentially epidemiologically important pathogens. So I did pull this from one of the studies. So some of those pathogens are things that we see on a fairly regular basis. We're familiar with them. So we're familiar with C. diff. We're familiar with Klebsiella. Most likely also familiar with ESBLs. MRSA, certainly, VRE. So those are some things that we're familiar with. So hopefully no surprises on that list of pathogens that potentially be considered epidemiologically important. All right, so in terms of transmission-based precautions, they are applied in addition to standard precautions. So we certainly don't want to forget about standard precautions. It seems like oftentimes, I spend most of my time in the nursing home setting, so it does seem like many times, we're good about wearing our gloves, but we sometimes just aren't thinking about splash and spray. Oh, I need to be wearing a face shield. I can share that it does seem like, and maybe this is a positive of the enhanced barrier precautions, it does seem like I'm getting that nursing homes are becoming much more aware and thinking a little bit more about, okay, wait, so if I'm putting someone that's on a trach on enhanced barrier precautions, well, what about the splash and spray? Well, that technically still falls under standard precautions, so we still need to wear that additional PPE in addition to those gowns and gloves to make sure that we're protecting our face. We do apply precautions presumptively. So if we have someone that is suspected of an infection or disease that would call for precautions, but we're not sure yet. So let's say we're waiting on a lab result, but we suspect that they have, we still go ahead and put them on precautions. So we don't want to delay. The reason for that is we certainly want to try to make sure that we're interrupting that chain of transmission as soon as possible. So we want to try to prevent any transmission before we know for sure. So we can always pull back on our precautions once we figure out for sure what's going on. But if we suspect something, we want to go ahead and put them on. And then the different types of precautions, they can be applied together. So we might have combinations of airborne and contact precautions. So again, they can be put together. I sometimes get questions from the nursing homes with concern about over-isolating. So I pulled the specific language from CMS. So this is a copy-paste. So you have the exact language. And CMS does allow for and is expecting us to empirically, so presumptively, empirically apply those transmission-based precautions. So a couple of examples. We think someone has C. diff, but it's going to take a little time to get the culture. Well, we go ahead and put them on precautions, even while we're waiting on that culture result, okay? So again, that presumptive, that empiric application of precautions, it is indeed expected and it is acceptable in regards to CMS. All right, so our airborne precautions. So within the CDC guidelines, CDC has historically defined and made differentiations between airborne precautions and droplet precautions based on the size of the particle. So airborne precautions being the smaller particles, my memory serves me correctly, I believe it's like less than 5 microns, and the droplets being greater than 5 microns. So, however, we have learned from COVID that we might need to be rethinking this. I am aware that CDC and HICPAC, they are working on updates to our isolation precautions. And as part of those updates, looking at how airborne and droplet is defined, or how are we going to redefine those categories as it relates to our respiratory infections and the precautions that need to be put in place. So, but in terms of, we still have the older guideline as our current guideline, and that is what I'm presenting today. But please be aware that this is subject to change in the future. So we're definitely anticipating some change in the future. So for someone to be properly put on airborne isolation, they need to be put into an airborne isolation room. So it's a single patient room, negative pressure. It's required to have 12 air changes per hour, air exhausted to the outside or through HEPA filtration prior to return. In terms of PPE that needs to be worn by staff going into the room, it does require an N95 mask, or you can wear a PAPR. Examples of infections that require airborne isolation: chickenpox, measles, tuberculosis, and disseminated shingles. So for droplet precautions, it's been kind of interesting to watch the tweaks in the language to this over the last few years. So CDC says in their isolation guideline, they have said, and originally said, mask upon room entry and eye protection used based on standard precautions. That language has been tweaked to say that we need to that we may want to consider making eye protection universal, since we don't know when a resident with respiratory symptoms might sneeze or cough. But technically, historically, it has just said mask for that room entry. And then the CMS survey pathway for the nursing home states mask and eye protection for room entry or when within 6 feet of a resident. So with a respiratory infection, calling for droplet precautions. So for the nursing homes out there, I recognize that there might be some confusion when reading CDC guidelines, depending on where you're reading within the CDC guidelines and on their web pages versus what appears to be the expectations from CMS. So CMS, their language says mask and eye protection for droplet precautions. A resident will be restricted to their room, and then we implement this for pathogens spread through close respiratory and mucous membrane contact with respiratory secretions in terms of that transmission. All right, our contact precautions. So that's our gowns and gloves upon room entry, discard upon exit. We want to use contact precautions when we know that the environment plays a significant role in the transmission of these pathogens. So as we've talked about in previous webinars, some pathogens are more viable in the environment than others, so they can live for longer periods of time outside of a host. So that would make them more viable, and the environment having a greater impact on the potential spread of the pathogen. We also want to make sure that even if we don't have an MDRO, we still want to use contact precautions For wound drainage, so if the wound is draining and it can't be contained, the dressing doesn't stay dry, we still want to be using contact precautions in the long-term care setting. Fecal incontinence or diarrhea or other discharges from the body that cannot be contained and suggest an increased potential for extensive environmental contamination and risk of transmission of a pathogen even before a specific organism has been identified. So again, relating back to, we still put someone contact precautions empirically or presumptively. And anytime that we have body fluid that cannot be contained, we want to be thinking about making sure that we are applying those contact precautions. All right, a couple things to be thinking about, some of those tweaks as it relates to our contact precautions. So for C. difficile, so having our signage remind us about the use of soap and water for hand hygiene when exiting the room. So this is clearly stated again in the CMS guidance, interpretive guidance. However, there's some softer language in the CDC guidelines, CDC being much more focused on, we just want you to make sure that you clean your hands, kind of a thing coming out of a C. diff room, and doesn't necessarily kind of require, so to speak, doesn't specifically state you always have to use soap and water, because they're very focused on hand cleaning. However, for the nursing homes, CMS does make it clear that they want to see the soap and water for the hand hygiene when exiting the room. That's another thing that I do see sometimes staff getting confused on with C. diff. You can still use hand sanitizer going into the room. The focus on the soap and water is coming out of the room. And then also we need specified cleaning products, cleaning disinfection products. So for the sporicidals or those products that are effective against C. diff, they're on EPA list K. And then for Candida auris, so the alcohol-based hand rub is indeed okay to use with Candida auris. And then also we have certain disinfection products that we need to make sure that we have reminders for as it relates to Candida auris. So those are on EPA list P. And then of note, I will just add that products that are on the C. diff list can also be used for Candida auris. So technically Candida auris can come from EPA list K or P, but nonetheless, list P is the one that is specific to Candida auris. All right, so how do we know which type of precautions we need for our patients or our residents? So Appendix A from CDC is a fantastic resource. You definitely want this to be your go-to. I can tell you that even though I've been doing this a long time, I still have to look things up. And actually, I got a question this morning from someone at a facility, and I had to go to Appendix A to look. It's been a long time since I've dealt with that particular pathogen, and I had to go look it up. So just to say, it's okay that you need to go and look. The important thing is you want to have the tool at your resource. You want to know where to go find the answers to the questions that you get. So I very much encourage you to save this as a favorite on your computer, save it as a favorite on your phones, because you might not be in front of your computer when you get that phone call or that text message with that question. So definitely make it easily accessible to yourself. So on the page, so even if you just, honestly, if you just do like a search engine CDC Appendix A, it should come right up. And when you scroll down that initial page, there's a section that says type and duration of precautions. You click on that link, and then it'll bring up that screenshot that I have on the right. And you'll see under there A, B, C, D, E, F, G. So those are all hyperlinks so to help you more quickly go to what you're looking for. I will concede sometimes within Appendix A, CDC will refer you to, so you go to what you think you're looking for, and they'll be like, oh, by the way, you need to go look over here for it. So sometimes it can be a little frustrating, but nonetheless, it is our primary resource for helping us to guide us on the type of precautions that are needed. So this is just an example. So it's not only can you look things up by pathogen, there's also some conditions that are listed. So for example, an abscess draining major, so contact and standard or until drainage stops or can be contained by a dressing. So this in particular is very important for the nursing homes, especially now that we have enhanced barrier precautions and when we kind of have that debate. So there are some conditions that are listed in addition to specific pathogens within Appendix A to help give us that guidance. And then you see the next one there, abscess draining minor. Then we can use standard precautions if the dressing covers and contains the drain. All right, so precautions can also be used in combination. So it's not just contact or it's not just airborne. So contact and droplet. So I just pulled a couple of examples. So let's see, adenovirus, pneumonia due to an MDRO. So so the combination between contact and droplet. We can also have contact and airborne. So shingles, so disseminated shingles, or localized shingles in an immunocompromised person would call for contact and airborne precautions. And then we kind of get ourselves in that quandary with COVID. It's not exactly droplet precautions because we need to wear the N95, but it's not airborne because we're not, CDC isn't requiring us to use the airborne isolation room. So some of that naming might vary, but just make sure it's clear to your staff whether you're calling it special droplet in contact, enhanced droplet in contact. We just want to make sure however you're calling it or naming it on your signage, we just want to make sure the staff understand. As far as CMS, some of the language in their interpretive guidance states that they do want the signs to indicate that the PPE, what PPE needs to be worn in the room. All right, so ideally, when we have someone on precautions, ideally we would be able to dedicate equipment that is used with that patient or resident. So, and if we can't dedicate equipment, then alternate practice is proper cleaning of shared equipment, especially like our non-critical equipment, blood pressure cuffs, thermometers, vital signs machines, things like that. Now, that being said, some of that non-critical equipment, we do have disposable available to us. Like there's now disposable blood pressure cuffs, there's disposable stethoscopes and things like that. So ideally, we'd pull out maybe some of that disposable equipment that we would keep in the resident room or patient room so that it is used with that patient while they are on precautions. All right, so patient placement. So ideally, we would have the patient or resident in a private room. That's our first choice, right? Our first choice. So acute infection with transmissible disease, ideally, we want them in a private room. Alternate option, placing residents together with the same pathogen in the same room. So both people have MRSA, we can put both MRSA people together, or both people have carbapenemase producing CRE, putting them together. Alternate option, and this is really trying to give some flexibility to nursing homes and long-term care setting, a risk-based approach and decisions made on a case-by-case basis. So in the long-term care environment, so we want to make decisions regarding patient placement on a case-by-case basis. We want to think about the risks for infection and the risk to the other people in the room, the presence of risk factors that increase the likelihood of transmission, and the potential adverse psychological impact on the infected or colonized patient. And actually, I was just in a facility this week, have a great example for this, because the facility, of course, had some questions about it. And so there were two people and they've been roommates for many years. And they're happy together. They want to be together. So roommates for, like I said, many, many years. And one of them had gone to the hospital. They had been identified as having Candida auris. So the facility is like, okay, well then I need to move. We don't want to keep him with that person. The roommates were, they were very unhappy. They wanted to be together. So the facility took great action. So they called and talked with the family of the roommate, explained what was going on, talked to them about Candida auris, and ultimately the family was like, no, this is what makes my loved one happy. I want her to have her roommate. So so anyway, so they got to stay together. So that was great. Oh, all right. So in terms of evaluating risk, so what is the risk of acquiring infection based on clinical diagnosis, epidemiology of disease, and mode of transmission? So So resident status, so things that make us more vulnerable to infection. Do we have draining wounds? Do we have devices? Are we immunocompromised? Do we have diabetes? So all those kinds of things make us more susceptible to infection, right? Which, thanks to enhanced barrier precautions, we are much more aware of these things, and we're currently thinking a lot more about these risk factors as we look at resident placement. So these are the kinds of things we want to be thinking about when trying to make those hard decisions about who's going to room with who, especially with those, let's say, with enhanced barrier precautions due to MDROs. So again, thinking about this, but let's not forget those psychosocial factors. So if we have roommates that want to be together and they've been together a long time, then let's see if we can make some exceptions and find a way to work with that. All right, so language that we have from CMS: residents on transmission-based precautions should remain in their rooms except for medically necessary care. So overall, we've gotten a lot better at that, in the long-term care setting. So we want to keep them in their rooms, and CMS says, yes, we can keep them in their rooms. So this applies to contact, droplet, and airborne precautions, or any combination of these types of precautions. All right, so when CDC doesn't specify length of time for precautions in Appendix A, so Appendix A sometimes gives us the answer for the duration of precautions, and sometimes it doesn't. So acute care, they have the luxury of saying, oh, until discharge. However, in nursing homes, we don't have that luxury, right? So we have to figure out, what does that criteria look like for when we can discontinue precautions? So a few things to kind of be thinking of. So we want to make sure that the resident is asymptomatic, and that body fluids are contained. And then other things that we can consider. So has treatment been completed? I do see a lot of facilities with policies that say asymptomatic, body fluid contained, and treatment completed, which for the most part works. However, sometimes we have scenarios where resident might be placed on an extended period of time for antibiotic use, which of course now opens up another door of questions in terms of antibiotic stewardship. But trying to keep on track with precautions and discontinuing precautions, you may want to make sure you have some flexibility within your policy, that even if someone hasn't finished an antibiotic, because let's say we are in extended use situation, that we have the ability to remove precautions, and then we can go deal with the antibiotic stewardship side of things. Does the resident maintain good hand hygiene? So what is the behavior of that resident? So certainly resident behaviors can influence our decisions. What does our surveillance data tell us? So did they have an MDRO? Does our surveillance indicate that we might have transmission currently going on for that MDRO? And if so, we might want to keep them in their room. If we're clearly not having any transmission of this pathogen, then perhaps we can go ahead and discontinue precautions. So again, our surveillance data can help us with that decision making. How long are they on precautions? Do we, or can we go ahead and discontinue precautions? And then what is your process? So we talk about process for discontinuing precautions. So in the acute care environment, they have until discharge. So they're going to have the terminal room cleaning, et cetera. But we also want to be thinking about that in the nursing home as well. So when we discontinue precautions, we want to define what that process is. We definitely want to implement that terminal room cleaning to include our privacy curtains. And then at what point do we stop wearing our PPE in the room? So we're wearing our PPE until the terminal room cleaning has been done. So making sure that that's clear to staff in terms of what that looks like. And then just to go back to, in terms of making those decisions for discontinuing precautions. So general rule of thumb, when someone is immunosuppressed, they are more likely to shed viral pathogens for a longer period of time. So some of you may have become more familiar with this during COVID. So when we look at the guidance for COVID and how long we keep someone on the precautions, and there's some language in there about extending the duration of precautions for COVID for people who may be immunocompromised. So that concept isn't just for COVID. It is a general standing guidance, if you will, as it relates to viral pathogens. All right, so we'll touch on enhanced barrier precautions. Enhanced barrier precautions, it is only applicable to the long-term care setting, so this is not an option for hospitals. It's kind of a halfway point in between standard and contact precautions. We're just wearing gowns and gloves for that high contact care. So CDC has outlined what counts as high contact care. I've included that here on this slide for your review. Getting a lot of questions as it relates to therapy. So do therapists need to wear gowns and gloves? Are we wearing gowns and gloves in the hallway? So yes, therapy when they're having high contact care, then yes, they would be wearing gowns and gloves. So we do need gowns and gloves in the gyms. However, we do not want gowns and gloves in the hallway. So we still want to stick by no gowns and gloves in the hallway. So if what you're doing for therapy requires that high contact care, that close contact, then we may need to move that therapy out of the hallway into the gym or into the resident room. Occupational therapy, so whether it's physical therapy, occupational therapy, this applies to both. So again, we have that language. So anticipate close physical contact. So the transfers, any high contact activity, high contact care activity. And I try to think of this in terms of kind of like, are we just touching their arm with our hand, or are we hugging them, kind of a thing? You know, do we have that body contact? Do we have that potential contact with our clothing? So high contact activity. All right, so there may be times we need to transfer a resident in a common area, such as a day room or dining room. Ideally, we don't want to be using gowns and gloves in these areas. So CDC does say, in general, we would not wear gowns and gloves in these areas when we have that short, quick contact, if you will, just to make that transfer. Changing linen is considered high contact resident care activity. So if housekeeping is doing the linens, we just need to make sure that they understand that. If your linens are being done by your CNAs, then we also want to make sure that they understand that they need to make sure they have on gowns and gloves for that. All right, so in terms of who is on enhanced barriers, so wounds, indwelling devices, anyone who's colonized or infected with a targeted MDRO, and then CMS says that we have discretion for those other epidemiologically important pathogens. So the novel and targeted MDROs, just as we reviewed earlier, they're the same. It's the consistent between CDC and CMS. So the list is the same. And then those that we have discretion on. So within the CMS guidance, they use the same list that CDC has in terms of examples of additionally epidemiologically important MDROs. So again, we can choose if we're including MRSA, ESBL, VRE, we're including those pathogens in our enhanced barrier precautions. So that being said, if you're not including something like MRSA and ESBL in your enhanced barrier precautions, and let's say those are pathogens that you do see within your facility, then I definitely think there's a challenge with, okay, then what are you going to do with these people? So from my perspective, I think it simplifies processes if you do indeed include MRSA and ESBL within your enhanced barrier precautions procedures, but nonetheless, CMS does say that we have some discretion there. So in terms of duration of enhanced barrier precautions, so resident with history of MDRO remains on ABP for duration of stay, even with negative cultures. So if you've had, let's say you've had Candida auris, you've had CRE, you're on forever, okay? If a resident is on due to an indwelling device or a wound, then they can be removed from EBP when that device is removed or when the wound heals, as long as they haven't had number one being the MDRO history. So, so sometimes you might have a wound, but if you had MRSA in the wound and you're including MRSA in your EBP processes, well, then they're on forever. All right, we still have to do contact precautions for acute diarrhea, draining wounds when it can't be contained. We also can do contact precautions when we have potential MDRO outbreak, or if we have ongoing transmission of an MDRO, and then any other infection listed in Appendix A that requires contact precautions. So differences, so contact precautions, we stay in our room, gowns and gloves for every room entry, and then we want to make sure that we can designate when we need the soap and water, when we need a sporicidal. So, you know, what are those signs, or how are staff notified and reminded of those things. And then EBP, resident can leave the room in gowns and gloves only for that high contact care. And we still have the same thing with EBP if we have certain pathogens that require a specific disinfectant, then we also want to make sure that we have a way to communicate that. All right, so in terms of room placement for residents with EBP, so acute infection with transmissible disease. So our first choice for a single room, that acute infection. Second, residents who need contact precautions, so they still require that based on the guidance, and then residents with enhanced barrier precautions. So that's kind of our priority for designating single rooms. As we discussed, just generally speaking with MDROs, for other types of precautions, so contact precautions, let's say, we can put roommates together who have the same pathogen. So for example, remember COVID units, so we're able to put people with the same pathogen together. Well, keep in mind, not everyone has the same pathogen. And then also we can be thinking about if we want to do, let's say we are accepting Candida auris residents and patients, then we might want to set up a wing specific to Candida auris, again, is that a supplemental strategy, if you will, to try to keep it contained. CMS does not require us to do that. Enhanced barrier precautions guidance does not require it, but it is certainly considered best practice. All right, so same concepts related to EBP and deciding room placement as we talked about with the other types of precautions. What are the risks to the residents in the room? Immunocompromised, wounds, indwelling devices, what are the risk factors that need to be taken into consideration? All right, so when residents are sharing a room on enhanced barrier precautions, so maintain that separation. We want to make sure staff understand that they have to remove their gowns and gloves, do their hand hygiene before caring for the other resident in the room. So we certainly want to make sure that staff understand that as part of their care. All right, so we still have some time for questions. And I will turn it back to Mina to help facilitate the questions.
Wonderful. Thank you so much, AC. I believe you just touched on this, but I want to ask it just to make sure the person who asked it gets a complete answer. She said many hospitals in our area do not isolate for MRSA colonization. What is your recommendation for isolating colonized patients?
So that's a great question, and that does lead to confusion. So there have been some changes, if you will. I almost want to be like it's a new movement. So in acute care, they do have some procedures in place where they no longer do isolate for MRSA, but that's usually coupled with a decolonization protocol. So in the acute care setting, they have a universal decolonization, so the chlorhexidine bathing, the nasal swabs occurring on let's say everybody in the ICU. So they may have universal protocols in place for decolonization, which when that's in place, then they have the option to not put people on precautions for MRSA. Coming into the nursing home setting. So again, I don't want to present this like it has to be this way because CMS does say we have discretion. My suggestion would be that yes, you do include MRSA in enhanced barrier precautions, and that someone coming in with a history of MRSA that you would indeed put them on enhanced barrier precautions. The rationale behind that is, one, I'm not sure, I think it gets very confusing when we start looking at MRSA in a wound. What are we supposed to do with them versus someone who was colonized coming in from the hospital? I think that can get very confusing, and that water can get very muddy on how we're going to stipulate what that looks like and define that in policy. Secondly, when you look at the studies that were done and that were referenced and that were used for the development of enhanced barrier precautions, a lot of those studies were done based on MRSA. So looking at the behavior of MRSA, looking at how MRSA is transmitted, looking at the impact of colonization versus infection, and do these strategies actually impact and mitigate the transmission? So a lot of the studies based on the development of enhanced barrier precautions used MRSA as their pathogen that they did all the culturing with, to track and to review this. So from that perspective, I would definitely encourage implementing enhanced barrier precautions for MRSA.
Sounds good. I just want to remind everyone, if you have questions, drop them in the Q&A. We have a few more to get to, but I know we have several minutes. One that came in a little earlier was, would it be recommended to include the other epidemiological important MDROs in a nursing home's enhanced barrier precautions policy?
So I think that overlaps a little bit with what we just discussed on the previous question, but in terms of, so let's say ESBL, VRE, so those ones that are specifically listed by CDC, my answer would be yes. Because again, that water is going to get, especially the common ones, especially the ones that you have more often that we regularly see, because then again, that water gets muddy. Well, what else are we going to do with them? When do we have to do contact? Well, we can't not do anything, and so on. So I would say yes. I have had some facilities take that even a step further and be asking about, well, how do you define an MDRO? And so when we look at that technical definition from CDC, so resistant to more than one class of antibiotics, then that's an MDRO. I don't know that I would go that far. So I would stick to those more common ones that we have and that are included on that CDC list. And then again, since I know we have people from multiple states, your state or your local health department might have some specific guidance, or they may have specified based on community surveillance what they deem to be an epidemiologically important organism in your area. So we certainly want to make sure that we are checking that as well.
Connected to that, there was a follow-up. Is there a way for nursing homes to know which local hospitals might have an increase in novel or targeted MDROs other than when they are being admitted to the facility?
I am not aware of formal surveillance information for that. I think, unfortunately, some of that is based on those informal communication channels. So that can be a more difficult decision when we don't have that formalized surveillance data. Again, if your public health does have formal data for you to work with and use, that's great, but not every place would have that. But I suspect, as you know, in the real world, the reality of it, we have a sense of what's going on in the hospitals around us. We know what kind of people they're sending us, and after a while, you know, we just kind of see where that is through some of that informal communication. And certainly, I think that there are some scenarios where we could potentially take action even in the face of formalized surveillance data.
Another question, in the acute care setting, how long should the decolonization last? Until discharge?
Decolonization last. So I'm wondering if that's like for the MRSA, the decolonization protocol.
If whoever asked that question, if you want to follow up, please feel free to add on to that Q&A, and I can clarify. Someone else said, if a resident has history of ESBL in urine, do they remain in enhanced barrier precautions for their entire stay?
So yes, if you are including, so ESBL falling into that discretionary list, but if you choose to include that in your enhanced barrier precautions, that answer is yes. So I'll just add on to that. Sometimes there's questions about, so if we have negative culture, do they still have to stay on even when we have a negative test? And that answer is yes. So there's this concept of transient colonization, so to speak, and that is we can be colonized for a period of time, then we might not be colonized, and then we can be colonized again. So really, unless we're swabbing people every day, we don't know when we're colonized, when we're not colonized, so that colonization can come and go. And that's the rationale behind once we've been colonized the MDRO, we stick with the EBP for duration of stay.
Would it be advantageous to use your facility's antibiogram to determine which MRDOs to add to the facility's policy for isolation?
Yes, that is potentially a good source of information. That's a great suggestion in terms of use. Yeah, absolutely. You could use that to look at what do you have in your facility? What are the concerns in your facility? Absolutely.
Someone asked a question if this presentation is being recorded and will they get a recording? Yes, all registrants will receive an email within 1 week of the webinar with a link to this recording, the slides, and the evaluation. And it will also be available on our website within that week as well. I'm looking to see if we have any other questions in the chat or the Q&A. I see some folks have given some shout outs of wonderful presentation. We'll see if that person has put anything else in the chat. They said regarding MRSA decolonization, should the decolonization process last until discharge if not applying contact precautions?
Yes. Yes, so that universal decolonization process is ongoing for duration of stay.
Well, that looks like all of the questions that we've received. I know we're almost at the top of the hour. I want to remind everyone of our next webinar, which will be May 23rd, reporting infectious diseases and outbreaks to the Alabama Department of Public Health. We hope to see you all there. AC, thank you again for being here. You've been with us for several webinars these past few weeks. So thank you again.
Thank you, and I'll miss you guys.
We hope to bring you back. Thank you again, everyone, and have a wonderful day.